Kypros, good morning.
Good morning.
It's Orhan from Cardiff.
Thank you.
Thank you. Thanks for accepting our invitation. We've been honored to have you in this session.
Thank you very much for inviting me. Are you there or are you in...
Yes, I am here in person in Kosovo. So we got a massive meeting here organized by Ramush Bejiki and Bayram and other colleagues, but also have a satellite session for mission to do operations in cardiac babies, so combining the two. But it's an honor to have you here, and I'm going to leave the co-chair person here, and she will say a few words about yourself.
Thank you very much.
Nora, for you?
Yes, thank you.
Yes.
Hello, Professor Nicolaides. It
Hello.
is our honor and it is our pleasure to have you here. First of all, I'll say a few words that it is not in the agenda of this Congress, but I have to say once again, thank you in the name of the director and all the colleagues from the gynecology and obstetrics clinics in Prishtina for your support for taking the first steps for the development of fetal medicine unit in Prishtina. So we appreciate that and we hope for further collaboration. Also, I want to thank you for your effort, your help, your support in training of the new doctors and helping us for further development of fetal medicine unit. The road of Kosovo, it's just one to Europe. And also there are criteria in the medical field for going to Europe. So you are a part of our history on that way in the field of obstetrics. And now I want to start the second session and invite you for the theme prediction and prevention of preeclampsia. Thank you.
I cannot see anybody there. I don't know if the connection is... I can see myself, but I cannot see you and I cannot see anybody else.
So our there is no camera. I'm sorry for the technological mishap. Sorry for the technological mishap. So unfortunately, we don't have our a camera on our side. So you won't be seeing us, but we'll be seeing the main actor yourself. That will have to be okay for everyone. I'm sorry.
Can you see my slides?
Yes, we can see your slides. I do profoundly apologize to you for not being able to see us, but we can see you. There's a technical problem here. Sorry, Kypros.
Don't apologize. As long as you can see me on the slides, that's enough.
Yeah.
First of all, thank you very much for your kind introduction. Yes, we did help to introduce through the Kypros Foundation a center in Kosovo, and my intention is to continue to support people from there. There's an open invitation for people to receive scholarships to come and train in London. We have this year received 2 excellent doctors from Albania, again, scholarships from the Kypros Foundation, and they're being trained. So I would be happy to do the same for anybody from Kosovo. Also, we have an alternative arrangement, because some people may not be able to come for 2 years, but they may be able to spend a few weeks or a few months in training, and we have arranged through the University of Thessaloniki that they can accept people from Kosovo.
Kypros, would you mind increasing the volume? We're having difficulty in hearing you.
Oh dear.
Please. I mean, we hear you, but not as loud as we would like to.
Can you hear me better now?
Better, much better, yes.
Much better, okay, maybe. Okay, so I was saying that my intention is to continue to support the people of Kosovo and to give scholarships to some of your best fellows to come here for a 2-year fellowship. Also, For those that are unable to spend 2 years in London, we have made arrangements that they can spend a few weeks or months in Greece, in Thessaloniki, to receive specific training. So I will talk about prediction and prevention of preeclampsia, and this is very much close to my heart and is part of my research. And the reason for that is very simple, really, that preeclampsia is a lethal condition. It kills more than 75,000 women and more than 500,000 babies every year in the world. And this picture on the right of Tori Bowie is of an American Olympic gold medalist who died 2 years ago at the age of 32, at 32 weeks in her pregnancy because of preeclampsia. Just to remind everybody that preeclampsia is a lethal condition. And yet, as I will show you, we have the potential to predict and prevent this condition, and I hold the governments responsible for not offering this to their populations. So, what are the methods that we have for the prediction of preeclampsia at the moment? In England and in the United States and in many countries of the world, we have a risk scoring system. When we first see women at the beginning of the pregnancy, we ask them a few questions, and if the answer to these questions or some of these questions is yes, then we classify them as being at high risk for preeclampsia. And if the answer to these questions is no, then they are at low risk of preeclampsia. So it's a very, very simple method, but it's not a very good method. When you look at the assessment of the method, we look at two things. What is the screen positive rate? What proportion of the population answer yes to some of these questions? And the second is, what is the detection rate? What proportion of the condition that we are screening for is included in the screen positive group? And the answer is the screen positive rate is about 10%, and the detection rate is about 40%. So as far as screening for preeclampsia is concerned, we are exactly where we used to be 50 years ago in screening for Down syndrome. We also had a very good method, which was very cheap. We were asking women, how old are you? And if they were over the age of 35, we used to tell them, you need to have an amniocentesis. The screen positive rate was 10%, and the detection rate was 40%. But many things have happened in the last 50 years in screening for Down syndrome. And the big breakthrough came with my research in 35 years ago, in 1992, when we described that we can look by ultrasound at 12 weeks, and you can look at the collection of fluid behind the baby's neck, and if the fluid is a little bit, then it's good, and if the fluid is a lot, as you can see in the bottom picture, then there's a high risk that the baby may have Down syndrome, other chromosomal abnormalities, cardiac defects, and many genetic syndromes. And we also described a method where you can take a blood sample and you can measure in the maternal blood the Flebita HCG and the PAVA, and if the values are high for HCG and low for PAVA, in combination with maternal age, nuclear translucency, and biochemistry, the triple test, we can identify not 40%, but 90% of the babies with Down syndrome. And that is 30 years ago. And in many countries of the world, this has become the standard method of screening for Down syndrome. Can we do the same, is the question. Can we move from the 40% to the 90% in screening for preeclampsia? Well, what did we do in screening for Downs? We combined the information from maternal age together with a biophysical test and a biochemical test. Can we do the same in screening for Downs, for preeclampsia? And the answer is yes, of course we can. We can get a prior risk, a starting risk, by asking a few questions in the maternal history and then measuring biomarkers. And then the values of the biomarkers can be used to modify the prior risk so that we can get a more accurate posterior risk. And this is the model. Hopefully it will work, this slide. Oops, there it is. This is the model. It's one slide and it's 30 years of work. And what does this slide say? can ask women a few questions: their age, their weight, their ethnicity. Did they have preeclampsia in a previous pregnancy? Did their mother have preeclampsia? Did they conceive naturally or by in vitro fertilization? And do they have chronic hypertension, diabetes, or autoimmune disease? And if the answer to these questions is yes, or some of the questions is yes, we combine the information through a multiple regression method to get a starting risk. That's the prior risk. And then at the 12 weeks of pregnancy, we use Doppler to assess the blood flow in the uterine arteries, uterine artery pulsability index, together with the measurement of maternal blood pressure and maternal serum placental growth factor. So this is the triple test for preeclampsia. And we did a major study in England in 7 hospitals where we combined the screening by the traditional method, the risk scoring, the pink histograms, against the Fetal Medicine Foundation triple test. And you can see the histograms, the Fetal Medicine Foundation blue, and the risk scoring red. The detection rate of early, preterm, and term preeclampsia with the triple test is exactly twice as much as with the risk scoring system. So the question in my mind is why is this not part of routine screening of the whole population? The next question is, do we need to do all 3 of the components of the triple test, blood pressure, Doppler, and PLGF? Some countries say that, like in England, we are a poor country, we have a lot of money for nuclear weapons, but not for measuring PLGF for the population. It is much better to invest in killing people rather than trying to save people. That's fine. Then they can do the double test. Or if they're in the United States, they have money to measure PLGF, but they don't know how to do uterine artery Doppler, for example, because they don't get paid for that, so they don't do it. So in these cases, you can do a double test, where you skip either the placental growth factor or you skip the uterine artery Doppler. What is the consequence of that? Well, instead of a detection rate of 90% of early preeclampsia, the detection is 81%, not too bad. Still a lot better than with the risk scoring system. So I tell people, do what you can, do the double test rather than the triple test. The next question is, having identified the high-risk group at the beginning of the pregnancy, can we actually do something to prevent the condition? And the answer is yes, we can. We have done a major study involving 27,000 women that in several European countries that had the first trimester screening test by the triple test. We identified the high-risk group, and then we randomized the women into 2 populations. One, where they received aspirin, 150 milligrams every day from 12 to 36 weeks, or placebo. And the results were amazing. We reduced the rate of the most severe type of preeclampsia, the one that is actually responsible for maternal and fetal deaths, preeclampsia before 32 weeks, by nearly 90%. We reduced preterm preeclampsia by 60%, but we had no impact on the rate of term preeclampsia. Perhaps the more important slide is the next one, because that talks to the politicians. In most countries of the world now, the biggest cost of pregnancy care is not obstetricians, it's neonatologists. In England, every day that the baby spends in the neonatal intensive care unit, it costs at least £2,500, 3,000 euros or dollars, however you want to convert the currency. We, as obstetricians in the national health system, receive about £1,500 for caring for pregnant women throughout pregnancy and the delivery. One day in the neonatal unit is £2,500. And what contributes to neonatal care is delivery before 32 weeks. You can see from the graph on the left, where we're looking at the cumulative rate of neonatal unit care, and that increases exponentially during the first 32 weeks of pregnancy, and then it's flat. Because in most countries of the world, babies born after 32 weeks survive and they don't need too much care. If we look at the total cost for one baby born before 32 weeks, on average is at least £100,000 per baby. And because many of these babies that survive quite often have various degrees of handicap, then the total cost of a lifetime for looking after some individual like this is, in England, 3 billion pounds every year. So if we could find an implementation of first trimester screening and treating with aspirin, we will pick up 90% of the early preeclampsias, and we will prevent 90% of the early preeclampsias by aspirin. And aspirin is extremely cheap. I do not understand why the governments do not implement this, but they are very obsessed about increasing their budget for weapons. The next question is, do we really need to continue to give aspirin to women until 36 weeks? There are some people that worry that by giving aspirin so late, we may result in hemorrhagic events for the woman and for the baby. There's no evidence of that. All of the trials on aspirin have not shown that you increase hemorrhagic events, but there's a theoretical risk. I know that old men like me that take aspirin have 3 times a higher risk of dying as a result of brain or gastrointestinal hemorrhage. So there is a potential risk that aspirin could increase these complications. So good, intelligent researcher from Spain, Manel Mendoza, suggested that perhaps we should stop the aspirin at around 24 weeks. Why continue until the end of pregnancy? So we have received funding now from the Bill Gates Foundation, and we will do a major study in England and Spain, where we will screen women, and then instead of using a screen positive rate of 10%, we will go for a screen positive rate of 30%. How do we achieve that? When we use a risk cutoff to classify somebody as being at high risk of 1 in 100, that classifies 10% of the population as being at high risk. If we use a risk cutoff of 1 in 250, that classifies 30% of the population as being at high risk. And that group is great because it will contain not 75, but 91% of the cases of preterm preeclampsia. So we can screen more, we can give aspirin to more, and potentially we will have a much greater impact on the overall rate of preterm preeclampsia. So the study will involve us doing that on everybody, and then at around 20 weeks, we randomize the women into 2 groups, one group where we stop the aspirin and the other group where we continue, and then we will see at the end whether it makes any difference whether you stop or 2 years, and I will tell you the answer. The next thing is that interesting, and I want you to learn something about the politics of science. There are repeated studies in this Cochrane library. The Cochrane library is meant to be the ultimate level of evidence in medicine. And a group of people, every 2 or 3 years, write a new review, a meta-analysis in this Cochrane database, and they say that calcium is fantastic. They use the same data from 13 studies on a total of 15,000 women, and they keep analyzing it again and again and again, and they keep writing more and more papers as if they need to have a lot of publications for their career. And then the same people influence the World Health Organization that sit and eat drink expensive wine and eat cheese fondue in Geneva. They are called the World Health Organization. And then every 2 or 3 years, they write the same rubbish. They say calcium is fantastic and people should take calcium because it reduces the rate of preeclampsia. Because I grew up with my grandfather. My grandfather is a Greek philosopher called Socrates. He said, believe nobody. Check what is the evidence and then find out the truth. So I said, okay, grandfather, I will check what is the evidence for this WHO. And this is the evidence. Remember, 13 studies, 15,000 women. This is the evidence. The biggest study is on 8,000 women. Villar, no effect. The second biggest study is from Levine, 4,000 women, no effect. But Nicolaides from Iran did a study of 30,000 women, or 30 women, not 30,000, and he said it's good. Lopez Jaramillo from, I don't know, Uruguay, another study of 50 women, he said it's quite good. And then after 3 years, he asked his mother permission to do another study of 100 women, he said it's fantastic. And then he asked his grandmother to do another study of 250 women, he said it's fantastic. And then they sit together and they do a meta-analysis. Meta-analysis is meant to be the ultimate level of medicine. I usually call it spaghetti alla carbonara in an Indian takeaway by a Greek cook and a Chinese waiter. They just put in a pot and they create a paella, measuring and combining everything so that Nicolaides, with 30 cases from Iran, is given the same importance as Villar with 8,500 cases. And they say it's fantastic. And then you get a headache. And you say, my God, what is the basis of scientific studies in medicine? If it's all like this, everything we do is rubbish. So we published a paper last year questioning the whole study. Here it is. These are the 13 studies. The first 3 studies accounting for 90% of the evidence. It doesn't help. And then the Jaramillo and his mother-in-law and his cousin and Nicolaides, they go together and then suddenly it's fantastic. But look what happens with the heterogeneity of the studies. When the studies are homogeneous, you can combine them. But when the studies are completely different, you cannot combine them. When they combine the extra studies, they increase the heterogeneity from 0 to 80%. Therefore, the conclusion, completely and absolutely useless. Calcium never did and never will prevent preeclampsia. Just for the record of the WHO and Cochrane review. The ultimate levels in medicine are rubbish. Next. Let us now look at term preeclampsia. If a woman develops preeclampsia at 28 weeks, it's a disaster because always the baby is going to be extremely small and you have 2 options really. You deliver the baby and it dies, or you prolong the pregnancy and the mother can die. But what happens if you develop preeclampsia at 40 weeks? Nobody cares. All you do is deliver the woman and nobody has to die. But is that true? Well, we did a study, we took 40,000 women at 20 weeks and we followed them up. The blue histograms is the incidence of adverse outcome due to preterm preeclampsia, and the pink due to term preeclampsia. And it is true that the incidence of adverse outcomes, maternal hypertension, maternal death, severe morbidity, perinatal mortality, neonatal admission, are always much higher in preterm than term. However, once more. If we look at the box on the left, the incidence of preterm preeclampsia is 0.7, of term preeclampsia is a lot more, 3%, and therefore, when we look at the overall impact of term preeclampsia, is much higher from term preeclampsia for adverse maternal events, and the substantial of adverse perinatal events are also the consequence of term preeclampsia. So term preeclampsia does matter. But what can we do about that? Well, it's a disaster, isn't it? Because first trimester screening by my method, the Fetal Medicine Foundation triple test is fantastic for early preeclampsia, not really good for term preeclampsia. And aspirin is great in the prevention of early preeclampsia, but it doesn't do anything to term preeclampsia. So what can we do? Well, the closer you are to the event, the greater is the chance that you will identify the event. You know, every day when we watch the news, we listen to the weatherman. And if the weatherman looks outside the window and says, today in London is really nice, the weather, it has a few clouds, but it's quite good, clear sky, then he gets it right. If he was to predict what would happen in 1 week, he always gets it wrong. So, if we want to predict what is going to happen at term with preeclampsia, we need to get very close to term. Because prediction at 12 weeks and 20 weeks and 32 weeks is not so great. So screening for term preeclampsia should be at 36 weeks. And if we do that, then we can identify about 80% of the women that will develop term preeclampsia. The method of screening in the first trimester is the triple test, blood pressure, Doppler, and PLGF. The method of screening in the third trimester is blood pressure, PLGF, and FLIT. FLIT is the anti-angiogenic factor. It's completely useless in the first trimester because it goes up about 3 weeks before the clinical onset of the disease. So not good in the beginning, but quite good at the end. Uterine artery Doppler is good in the beginning for identifying impaired presentation, but most of the term preeclampsia are not due to impaired presentation. So uterine artery Doppler is not useful. So here we are, 36 weeks. But what else can we do at 36 weeks? I have been campaigning for a few years now that all women should have a minimum of 3 routine ultrasound scans in pregnancy, 12, 20, and 36 weeks. Why 36 weeks? Because we can identify the abnormal presentation, we can identify some third trimester anomalies that are not apparent earlier, and we can identify accurately small and large babies in a way that we cannot at 20 or 32 weeks. And as part of the same package, we can screen for term preeclampsia. And then what? Well, this is called personalized medicine. Every day, you keep hearing people talking about this personalized medicine, but nobody practices personalized medicine. Personalized medicine means you assess the risk for each individual person, and based on their individual risk, you give them a special individual clinical management. Who does that? Nobody, of course, does that. But for 10 years, you have been talking about personalized medicine, blah, blah, blah. Well, this is what personalized medicine is. At 36 weeks, we assess the personal risk for each woman of developing preeclampsia. And if the risk is extremely high, like 1 in 2, we deliver these women at 37 weeks. 1 in 5, 38 weeks. 1 in 20, 39 weeks. 1 in 50, 40 weeks, and so on. So the timing of birth is based on your personal risk. And the logic here is quite simple, really. Can we fool preeclampsia? If I know that the woman is going to develop preeclampsia tomorrow, can I deliver her today to prevent her from getting preeclampsia tomorrow? The answer is yes. It sounds clever, but what about if she doesn't develop preeclampsia before delivery, but she develops it in the neonatal unit? So we had to find out, and we did a study. We took 8,000 women, and we randomized them into 2 groups. And in one group, we let them carry on being managed as usual. And in the other group, we decided their risk, and then we did this personalized assessment and personalized decision of when to deliver them. And it was fantastic. We reduced the rate of term preeclampsia by 30% without increasing the rate of postnatal preeclampsia, without increasing the rate of neonatal unit admission, because we were delivering some babies prematurely, and without increasing the rate of cesarean section, because we were inducing labor, so we were afraid that we could potentially increase the rate of cesarean section. So that's good news. And this month, the results will be published in the Lancet. So here we are. We have, the last few years, developed a method of first trimester screening and prevention, and third trimester screening and prevention of term pregnancy. Now let me quickly go through what are the useful biomarkers at different stages in pregnancy. The measurement of blood pressure, of course, is always useful because preeclampsia is a disease of blood pressure. The measurement of placental growth factor is always useful because you have impaired placental function. Uterine artery Doppler is useful for the prediction of preterm preeclampsia, not useful in the prediction of term preeclampsia, and FLIT is useful in the prediction of preeclampsia that happens after 3 weeks, not preeclampsia that happens in the first trimester. What about maternal cardiac function? We have known for a few years that if a woman develops preeclampsia, she and her child are at increased risk of dying a few years later from cardiovascular disease. So the question is whether preeclampsia damages your blood vessels and then you go and die a few years later from these damaged blood vessels or damaged heart. So we did a big study where we took nearly 5,000 women, now it's 8,000 women, at 20 weeks in pregnancy. And we did maternal cardiac function to see whether that was different in women that will subsequently develop preeclampsia. And the answer is, if you look at the vertical black line, that is normality, and the horizontal black lines is what we found in women that subsequently developed preeclampsia. And you can see the black lines for ventricular diastolic and systolic function and structural abnormalities of the heart or hemodynamic parameters was not really different in the women that developed preeclampsia, except one thing, the red thing. And that is peripheral vascular resistance. Wow. So, women that will develop preeclampsia have increased peripheral vascular resistance that is obvious from the second trimester of pregnancy. We are doing studies now in women before they have IVF, and they are already observing increased peripheral resistance before they even think of getting pregnant. So, the story is very simple for me. Women that have a degree of increased peripheral resistance before they get pregnant, they tilt over and they develop preeclampsia during pregnancy. Then the pregnancy is gone, the preeclampsia is gone, but they still have increased peripheral resistance, and because of that, they will develop chronic hypertension and they will die a few years later. So preeclampsia does not damage your vessels or your heart, but the other way around. The damaged vessels is what predisposes to the development of preeclampsia. But it's quite difficult, really. I take my best research fellows, and we take 3 months to train them to do a maternal echo. Is there something simpler that we can do to assess peripheral vascular resistance? It doesn't take 3 months. It doesn't take several efforts. And the answer is yes, we can. Watch. I'm drinking coffee. You take the ultrasound machine, you finish the scan, you put a bit of gel, and then you ask the woman to close her eyes, and you place the transducer on the eye. It's a miracle. You can see a big black sphere. What is that? It's not the knee or the testicle, it's the orbit. You put the color on, and there's only one vessel, and that is the ophthalmic artery. The ophthalmic artery is the first branch of the internal carotid artery. It takes a few seconds to do this, and it takes 1 or 2 minutes to learn how to do it. So all people involved in obstetrics should be doing this all the time. And it's interesting, because the heart contracts. Blood goes into the internal carotid artery, and then it goes into the ophthalmic artery, and you get the first wave. And then the blood goes to the periphery, it hits the small arterioles, and it is reflected back to the heart and again into the brain. Then you get the second wave. So the first wave is cardiac contractility, the second wave is peripheral vascular resistance. 1 minute of training and 1 second for assessment. The second peak systolic velocity. You have done studies now involving 15,000 women at 36 weeks, 3,000 women at 20 weeks, 4,000 women in the first semester. The blue horizontal lines are normality. The red circles are from women that subsequently develop preeclampsia. You can see that in women that will develop preeclampsia after a few days, after a few weeks, after a few months, already the second wave, the peripheral vascular resistance wave, is increased. I've now worked with an Indian company that helps automate the assessment of the ophthalmic artery. Just put the transducer on the eye, and then the transducer tells you move to the left, move to the right, up or down, and then you get a perfect wave. And when you do the wave, then we use artificial intelligence, and we characterize the waveform. And from the characterization of the waveform, we don't need to measure anymore the first or the second wave. We can already improve the prediction over and above of what we get from the measurement of placental growth factor or FLIT. So unfortunately, the biochemical companies will kill me because they will lose a lot of money, but obstetricians can do this on their own, and they can control the pregnancy. So here we are. This woman died. And this woman died in America because America is a very primitive country. It invests enormous amounts of money on nuclear weapons in stimulating wars throughout the world. There's no other country in the world that has been responsible for killing as many people as America has. But it is really good in killing people and developing nuclear weapons, but it doesn't have the decency, doesn't have the moral principle to invest in health. And the big chunk of the population, especially the blacks, especially the poor, do not have health care in America. That is why the perinatal mortality in America is higher than in Cuba. That's why they hate the Cubans so much. It's very sad, really. And this goes for killing a gold medalist, an Olympic gold medalist. Imagine for the rest of the population. So we have the ability today to predict in the first trimester the women that will develop preterm preeclampsia, and with a very cheap drug that is safe, aspirin, can go a long way towards preventing the death of women like her. And you can also, by screening in the third trimester, perhaps by a combination of blood pressure and ophthalmic artery Doppler, can identify the women that will develop term preeclampsia, and by timing their birth, we can prevent term preeclampsia. So that is the end of my first lecture. If anybody wants to ask me any questions, I will be happy to discuss things with you.
Kypros, it was absolutely astounding. I'm sure the audience will agree with me. It was very enlightening, and particularly your personal, very powerful views on delivering equal care to the all walks of life was very moving, I must say. And I really applaud you from the bottom of my heart. We share the same sentiment and great respect. Now, I'd like to ask audience if there is anybody willing to shake this man of knowledge and get the fruit out of him. Any question, please, to the legend, that question.
They're very shy.
Yes, we are trying to stimulate since this morning. And yes, I have one from the audience, then Tanopoulos will ask also. Yeah, the front.
Greetings from here. I would like to ask this dose of aspirin from 150 milligrams should be divided in half, 2 doses twice a day, or should it be taken at once, only once a day?
In England, the dose of aspirin is 75 milligrams.
Yeah.
So women take 2 tablets. There is a study from Spain, a very interesting study, where they showed that if you take the aspirin at night rather than in the morning, you have a better control of the blood pressure. So in the aspirin trial, we are giving 2 tablets of 75 milligrams, that's 150, and we are giving them at night. So I don't think that it's necessary to divide it, because I hate doctors and I hate medicines. And the biggest problems in medicine is compliance with the medication. We found that if you, in the overall study, we reduced the rate of preterm preeclampsia by 75%, by 60%. But if we looked at the subgroup of women that took 90% of the tablets or more, the reduction was 80%. People don't like taking tablets, they forget taking, but I know for myself, if I keep getting chest infections, I take antibiotics for 2 days. The doctors always tell me to take them for 7 days. If I feel better after 2 days, I throw them in the toilet. So my answer is simple, really. Make life easier for people. Take 150 milligrams in 1 dose.
Thank you very much indeed.
Did you say 1 dose in the morning or at night? Sorry.
It doesn't matter really. Although in the trial we use them at night, I think
But
it's easy.
it won't harm the stomach, so you don't give any...
Yes, it's better to have some food in your stomach. So you have breakfast and take the aspirin.
There is one more question from Apostolos Athanasidias.
Hi, Kypros.
What is he doing there? What are you doing?
Just traveling.
I see.
You mentioned Aristotle University, so I came to represent our country.
I also, first of all, I'm grateful to the university because, unfortunately, a lot of the people are nowadays women, and in some countries, women get married early, and they have their families, and it is very difficult for them to come to England for the 2-year fellowships. And the Aristotle University have agreed for these people to come for a few days or a few weeks, and the Fetal Medicine Foundation will cover their expenses of traveling and staying. So it's nice that you're there already supporting this effort. Thank you.
Okay, Kypros, thank you so much for sharing all this data with us and for the continuing research on this matter. I want to continue the issue of aspirin. If we have G6PD absence, what we are doing?
I don't know. Fortunately, it's not very, very common. So nothing really. We just monitor those women more closely to see if they develop preeclampsia and then manage them appropriately. There'll be a few women also that have aspirin allergy, but I haven't got any answer as to what to do with them. Just monitor them more closely.
And the second question is because in many countries, SF1 and the biomarkers PLGF are very expensive.
Yes.
Do you have to do them in first trimester, or it's better to perform them if we want during the second trimester?
It's simple, Apostle. So first of all, the ideal method in the first trimester is the triple test: blood pressure, uterine artery, and PLGF. However, if we do screening for Downs and we only do age plus nuchal, the detection rate is 80%. By adding free beta HCG and PABA, we increase the detection by 10 points to 90%. It's exactly the same, really. If we skip the PLGF, we get to 80% rather than 90%. But what we can then do is increase the screen positive rate. Instead of using a risk cutoff of 1 in 100, which gives you a 10% screen positive rate, you can use a screen cutoff of 1 in 150, which will give you a screen positive rate of 15% and still achieve the 90% detection, if you see what I mean. So you skip one of the biomarkers, you increase the screen positive rate, so you give aspirin to 15% rather than 10% of the population, and you achieve the same detection rate.
Kypros, I have a question myself as a pediatric cardiologist. I love magnesium. And I do actually limit the use of calcium in pregnant women when they present with a baby of irregular heart rhythm or arrhythmias. We know, as electrophysiologist myself, calcium is in the mechanism of ectopic beats and arrhythmias. Do you think there is a place for prevention of preeclampsia by modifying the diet with magnesium-rich food, magnesium-rich nutrients or whatever, and also additional supplementation? If so, would you recommend any particular type, like magnesium bisglycinate, magnesium citrate, magnesium phenidate, or else? Thank you.
Thank you very much. A nice suggestion. People have tried all sorts of vitamins and metabolites, really, without success. Magnesium is not one of the substances that have been investigated. So I cannot give you an answer as to whether it is useful or not. Maybe in my next life, we can do a trial to see if it works.
Well, we can collaborate together. I mean, not next life, in this life. You got many more years for Dalia. I'm sure you will say Dalia.
You're very kind. Thank you.
Maybe ask you to proceed to second talk, perhaps, if everybody's waiting eagerly. Thank you.
Thank you very much. So, the second slide, the second lecture is, did I get out of the system? Are you still there? Am I still there or am I out? Yes, I'm still there. Okay, the second lecture is on preterm birth. So here we have preeclampsia, which is one of the main causes of maternal mortality, and preterm birth is by far the most important cause of perinatal mortality. So let's see whether I can share. Can you see the presentation?
Yes, we can see it. Can you see us now? So
yes, I can see.
Excellent. So at least we can show some respect to you by showing our faces. Thank you.
Thank you very much indeed. So, preterm birth. Let's go for that now. And here is the global reality of preterm birth. 15 million babies born every year prematurely, and more than 1 million babies die every year as a result of prematurity. You can see really one of the big problem areas, the ones that are dark blue, Southeast Asia, India, Bangladesh, Pakistan, because of poverty. A few African countries, sub-Saharan Africa, a combination of poverty and infections, and Latin America, especially Brazil, where again there's a big inequality in the socioeconomic situation of the population. So people have tried, and they have challenged the system for the last few decades to reduce the rate of preterm birth, and all sorts of different methods have been tried. And these are the results, the most recent results, that show, first of all, that we have not managed to reduce the rate of preterm birth in developed countries in the last 50 years, and these are the results from the last few years in the United States, where the rate is twice as high as in England, because of what I said, mainly poor and black people, so nobody cares about them anyway. But the rate is the same. Now, I made this slide with ChatGPT, which is a very good source of learning for me nowadays. You try to answer the question of what is the risk of a baby dying, or if it survives, of being handicapped at different stages in pregnancy. And you have important trials from the United States, the Neonatal Research Network, and the EpiPage study from France. And I combined that information together with a series of large global meta-analysis on more than 30 cohorts. And this is a summary, and if you want to take a slide, a photograph, just take this. Every week, in every hospital in England, you have the same stupid discussion. What is the chance of a baby dying? What is the chance of a baby surviving and being handicapped at different stages of pregnancy? Very simple, really. If a baby is born at 22 weeks, it has a 95% chance of dying, and if it survives, it has a 65% chance of being handicapped. But you can see how dramatically the rates of both death and handicap decrease. And by the time really we reach 32 weeks, they are almost nothing. A baby born at 32, 33, 34 weeks has more or less the same chance of surviving as a baby born at 40 weeks, and more or less the same chance of being well as a baby born at 10. So the big problem, as far as preterm birth is concerned, is 22 to 32 weeks. That is what kills babies. Now, there are two reasons why babies are born very prematurely. And if I take this population from our hospital, I took 120,000 pregnancies that were delivered at King's between 2006 and 2024. And the babies that were born before 32 weeks, it's 1% of the population. So it's extraordinary, really, how 1% of the population contribute to so many millions of babies being born prematurely, becoming handicapped or dying. We then look at that population and you can split them up into two groups. Iatrogenic, medically indicated preterm birth, because the baby is small, because the woman has developed preeclampsia, or some other medical indication, but the vast majority of medical indications are preeclampsia and fetal growth restriction. And then spontaneous preterm birth, which is 2/3 more or less of this 1%. Let me then go and see how do we go about trying to find out who are the women that are going to deliver very prematurely. And there are three ways in which we can do that. We can look at maternal factors, take a history. We can look at markers of infection or inflammation, and you can measure cervical length. In terms of the history, in this study, it's obvious really, the shorter you are, the smaller your cervix, the greater is the chance that you will deliver prematurely. If you are black, it's bad news. You have 3 times as much a chance of delivering prematurely than if you are white. If you smoke, if you got pregnant by IVF or by ovulation induction. And then, very important is how did you behave in your previous pregnancy? If you delivered before between 16 and 33 weeks once, the chances of repetition of very premature birth is not 1% anymore, but is 10 times higher, is 10%. And if you have had 2 such events, your risk is 20 times as much, is 20%. If, on the other hand, in a previous pregnancy you delivered at 10, then that is protective, and your chances of delivering prematurely is half as much. So that's the history. But that's not enough. It's the same as the risk scoring system that I discussed for preeclampsia and for Down syndrome. We can only identify 1/3 of the babies that will be born prematurely. It's not a really good method. It's just an assessment of the risk as the basis for inclusion in an algorithm that includes biomarkers. And if you go to the Fetal Medicine Foundation website, it's free of charge. You can put these maternal characteristics for any patient, and then the computer gives you the personalized risk. In 3 weeks from now, the Fetal Medicine Foundation will release our new software that will be given to the whole world for free. So all of you can get this software and you can use it in your clinics, in your daily practice, so that you can calculate the risk of preeclampsia and Downs and everything else, including preterm birth. Infection and inflammation is interesting. Really, we have for many, many decades been discussing this as the source of triggering premature birth. If you have an infection somewhere, you have inflammation, and somehow this inflammation produces contraction. The best candidate, of course, is bacterial vaginosis, but repeated studies have shown that if you have bacterial vaginosis, which is very common in women, every time you examine a woman, there's a 25% chance that she will be positive. If you don't do anything to her, then it will disappear, and the next time you examine her, there will be 25% other women that will have this bacterial vaginosis. Your risk is increased. But can we do something to prevent this risk? There are repeated trials that have tried antibiotics, and they have shown that that does not prevent preterm birth. There is some evidence, perhaps, that if you give antibiotics starting early from the first trimester, perhaps you can reduce the rate. But overall, the conclusion from all of the trials is that, yes, if you have bacterial vaginosis, your risk is increased, but unfortunately, you cannot prevent it by getting antibiotics. Right. The top woman looks quite nice. The bottom woman, God knows who managed to get to have sex with her. Maybe the husband looks exactly the same as her. If she looks like the bottom woman, then she has an increased risk of premature birth. The real question is, if you send her to a dentist and you clean up her teeth and she looks really good, is her risk of premature birth reduced? The answer is, unfortunately, not. And this is very interesting. So, to me, what this means is not the infection that matters, but it is the type of a woman that gets the infection that is predisposed to getting premature birth, rather than the infection or inflammation per se. Again, it goes back to poverty and social deprivation, really. What can you do about that? The next thing is fetal fibronectin. There is an association with this fetal fibronectin and increased risk of premature birth. It was temporarily used, but it has now, at least in England, been abandoned. Again, if you are fibronectin positive and you gave these women antibiotics, not only did you not reduce the rate of preeclampsia or preterm birth, but actually you increased it. Maybe by giving antibiotics, you're disturbing the natural vaginal flora, and you are introducing more pathogens, and therefore you are increasing rather than reducing the risk of preterm birth. So inflammation, infection is interesting. To me, they are markers of social deprivation rather than true etiological factors for preterm birth. Cervical length is important because at the end of the day, for a baby to drop out of the uterus, the cervix must open up. So if you measure the cervix, and the cervix is short, it's more likely that it will open up than if the cervix is long. And this is a distribution of measurements in 81,000 women that we examined at around 22 weeks. The average cervical length is 32 millimeters. In 5% of the population is below 25 millimeters, in 2% below 20 millimeters, and in 1% below 15 millimeters. And what does it matter? Well, you can see on the right really the implications of a short cervix. If the cervix is less than 10 millimeters, you have a 50% chance that you will end up delivering before 32 weeks. And if it's between 11 and 15, it's about 30% and 10% and so on. So there's a very clear relationship between cervical length and subsequent premature birth. And a few years ago, we published, it's a lot of time actually, 2008, it's already nearly 20 years ago, we published a method which combines maternal characteristics together with the measurement of cervical length, and then you can identify the vast majority of the women that will be delivering before 28 weeks. We're not so good in predicting premature birth at 36 weeks, but who cares about premature birth at 36 weeks? What matters is the most severe early premature births. So, we have a method of identifying the high-risk group, and then what do we do? Well, this is one of the, here is your magnesium. One of the things that people do, I'm sure they do it in Greece, and I'm sure they do it in Kosovo, as soon as you have a woman, you put her in bed. I consider that to be criminal activity. It's sadomasochism. I hate hospitals, I hate doctors, and I hate bed rest. Every time I go into the hospital because I cannot breathe, and they ask me to stay in bed, I take my own discharge and I go home. You stay in bed, and what does that do? It doesn't prevent preterm birth, for sure it does not, but it drives you mad. It can increase your risk of dying because of venous thrombosis, muscle atrophy, stress, economic cost, without any real benefit. So don't punish women by putting them in bed. Now, people have suggested that they have to put on weight or increase antenatal clinic, have psychological support, decrease manual work, but none of this has actually worked. They had a very nice study in Zimbabwe, old Rhodesia, where they took women with twins, and they took one group in the hospital, and the other ones, they asked them to continue to go into the fields and dig the fields. The rate of preterm birth in those that were in the hospital was higher than in those that were digging the fields. So you might as well carry on with manual labor. And then people are giving anything you can feel like to people, and there are some women walking around the big handbag with fake Valentino bags full of drugs that none of them work. So what can you do? Well, progestogens. And you can give them prophylactically for women that had a previous preterm birth. Remember what I said, the chance of the most severe preterm birth is 1%, and if you had a previous preterm birth, it's 10% or 20% if you had two. So if you have a woman that had a previous preterm birth, pump her up with progesterone. Does that work? Actually, unfortunately, not. In women, however, that are found to have a short cervix, progesterone does work. Now, people also that hate women, doctors that are sadists, they give 17-hydroxyprogesterone. These are deep intramuscular injections that are really painful. Last week I went to have my COVID injection. It was a deep intramuscular injection, and I nearly punched the doctor in the face. Well, they are punishing women by asking them to have deep intramuscular injections of 17-hydroxyprogesterone every day. It doesn't work. There was a study that showed that it did work, and this is, again, a criminal activity in the United States. The company that got the rights to sell progesterone on the basis of this study increased the price from $10 to $1,200. They should be put in prison, these people for being criminals, because the very group that is at the highest risk of premature birth, they ask them to pay money that they cannot pay. And then there was another study a few years later, and showed that 17-hydroxyprogesterone does not work. Does not, it never did, and it does not work. 17-hydroxyprogesterone. What about vaginal progesterone for previous preterm birth? And the answer is, there are some studies that show that it's useful, but overall, when you look at the results and you make adjustments for the size and the very high risk of bias, vaginal progesterone as a prophylactic measure on the basis of the evidence that we have at the moment does not prevent preterm birth. What about vaginal progesterone for women with a short cervix? We did a study, it's a long time now, it's 20 years ago, where we showed that if the cervix is short and you give progesterone, 200 milligrams every night, because it's messy really. You leak, and if you take it during the day, it makes a mess with your clothes. So vaginal progesterone every night, 200 milligrams vaginally, that reduces the rate of preterm birth by about 45%. And then the group of Roberto Romero in the United States did exactly the same study, and they also found exactly the same results. So if you have a short cervix, vaginal progesterone is useful. And then this is more recent analysis of all of the studies put together, and it shows that we are reducing the rate overall by about 40%. What about cervical cerclage? Again, who should have cervical cerclage? If you had a previous preterm birth, should you put a stitch? And when should you put in a stitch? And who should put in a stitch? And what type of a stitch should it be? And secondly, should you put in a stitch if you find that the cervix is short? A very good study many decades ago, more than 30 years ago, in England had shown that it is only beneficial to put a prophylactic cerclage if you have had three previous late miscarriages or preterm births. 3. For the rest of the population that had 1 or 2 previous preterm births, the logic is to actually ask these women to have measurement of cervical length starting from 16 weeks every 1 or 2 weeks, and only if the cervix is short, then to put in a stitch. And this is a study that we have done, and it shows that in women without a previous preterm birth in the short cervix, as a first-line measure, cervical cerclage was not useful, but for women that had a previous preterm birth or a late miscarriage and the cervix is short in this pregnancy, then cerclage reduces the rate of preterm birth by about 40%. So what is the logic of what I advocate? Simple, really. If a woman had a previous preterm birth, 1 or 2, 3, put in a stitch at 12 weeks after you do the nuchal scan and you make sure that the baby looks normal. If they had only 1 or 2 previous preterm births, ask the women to come back at 16 weeks and start measuring the cervix. If the cervix is less than 25 millimeters, give them progesterone, look at them again after a week. If the cervix is stable, great. And if the cervix is further shortening, then put in a stitch. Quite simple, really. And then pessary. I have a very good friend in Germany. Her name is Bine Arabin. It's interesting how daughters always love their fathers. I have a daughter and she comes to me every time she needs money and she tells me that she loves me. I ask her, is it me that you love or my money? She said, Daddy, how can you be so cruel? Of course I love you, but can you also give me some money? What can you do? So, Professor Arabin, the father, was a good gynecologist, and he developed this nice pessary to put in the vagina of women that had a prolapse. And then he had a factory and he made a lot of money from using the pessaries to prevent prolapse. And then he died, and the daughter wanted to honor the father, and she wanted to continue with the factory. And she came to me and said, Kypros, in Germany, I put this pessary in women and they don't deliver prematurely. I said, this is fantastic. Of course, the German women are big women, they're tall, and they are generally well off. Germany is the richest country in the world. And therefore, the rate of preterm birth is very low anyway. So, I was in Barcelona once, and we sat with Bine. I used to smoke 80 Marlboro a day. We were having a cigarette. I was having a cigarette, and she was talking. She loves talking. And I have a very good friend there, Elena Carreras, in Barcelona. And we sat together and said, let's do a study of putting this pessary in And they planned the study in Barcelona, and they produced fantastic results. The Goya was the first of all. They took women, they measured the cervix. If the cervix was less than 25 millimeters, they randomized them into a group where they were putting the pessary and a group that they did not. In the group that they did not put the pessary, the rate of early preterm birth was 27%, which is unbelievably high. And in the group where they put the pessary, it was only 6%, and that was a miracle because you stick in this pessary, no operations, and that's it. You are now preventing preterm birth. Everybody was excited. And then I said, well, let me repeat that study. A few years later, they examined 380 women, I examined 930, absolutely no effect at all. Actually, then they were telling me, baby, the English women have a different cervix. I said, yeah, you're right. But a lot of my friends and a lot of my students are in Spain. So half of the patients in this trial were actually from Spain as well. So we were stuck really. Is the pessary fantastic or is the pessary completely useless? And then there were many other studies. This is the Goya study from Barcelona, another one from Naples, but most other studies were not showing an effect. And the overall conclusion today from putting all the studies together is that the pessary is not useful. So simple. Take a history. No previous preterm births. Survival assessment on everybody at 20 weeks. The cervix is short, less than 25, 200 milligrams of progesterone vaginally. See the women after 1 or 2 weeks. Stable cervix, say bye-bye. Shortened cervix to the stitch. 3 previous late miscarriage of preterm births. Do a scan at 12 weeks, make sure that the baby looks normal, and then within a stitch. 1 or 2 previous preterm births, see the women at 16 weeks, measure the cervix, and do that serially until 24 weeks. And if only the cervix is short, then put in a stitch. Multiple pregnancy, disaster. Why is it a disaster? Of course it's a disaster. The rate of preterm birth in a singleton pregnancy before 32 weeks, about 1%, before 34 weeks, 1.7%. In a twin pregnancy, the risk is massive. It's 10 times higher. It's 15% in a dichorionic twin. It's 28% in a monochorionic twin. So, although twins constitute about 1 or 2% of the population, they are responsible for 25% of all preterm births. So, twins, bad news in terms of preterm birth. What can we do? Well, in singleton pregnancies, bed rest does not work. In twin pregnancies, for sure it doesn't work. And there was one study where almost the rate of neonatal death in those that were in bed rest was increased. So don't put women with twins in bed. Ask them to run around, but not to go to the shops and spend your money, like my daughter, but to carry on doing their jobs. Cervical cerclage. Cervical cerclage in singletons with a very short cervix is useful. Unfortunately, all of the trials are now showing that because it's much more difficult technically to put in a stitch, maybe by putting in a stitch, you're rupturing the membranes. So you're doing more harm than good. Progesterone, disaster. I did a study involving 1,000 women where we gave them a lot of progesterone, not 200 milligrams. I said we will blast them. We'll give them 600 milligrams of progesterone starting from 12 weeks. Placebo progesterone on the right, no difference. It wasn't useful. I was very depressed and disappointed, and then we looked at the results again. It was not useful overall, but in a subgroup of women that had a shortish cervix of less than 30 millimeters, then there was a substantial reduction in the rate of preterm birth, not in those with a long cervix. So perhaps progesterone, like in singletons, with a short cervix, does help. And what about this is an overall study again, prevention of preterm birth. This is what happens in singleton pregnancies. And the latest meta-analysis from Roberto Romero is that perhaps in women with a short cervix and twins, like in singleton pregnancies, you are reducing the rate of preterm birth by about 40%. So that's good. What about the pessary? In all twins, nothing from these two big studies, including my own study on more than 1,000 women. But there was again some contradictory evidence. One which showed that perhaps in women with a short cervix, not overall, in women with a short cervix, the pessary is beneficial. The two studies on the left, again Goya, and then studies from me and others which show that it is not beneficial. The latest meta-analysis showing that the pessary in twin pregnancies with a short cervix is not beneficial. So, coming to the end, summary. Singleton pregnancy, previous preterm birth, 16 to 34 weeks, cerclasia 12 weeks. 1 or 2 previous preterm births, cervical assessment, starting from 15 weeks. If the cervix is short, less than 25 millimeters, give them progesterone, see them again, and put in a stitch if it gets further shortening. No previous preterm birth, routine scan on everybody at 20 weeks, again, a short cervix, progesterone. And then in twins, again, cervical assessment, and if the cervix is short, progesterone. I am sure that you have a headache. Thank you.
It's an absolute feast. Thank you very much. So enlightening, as so typical of you. Thank you. So I'm sure the audience will be very excited to ask questions. So
they want to have coffee. They want to go out and
no doubt about
have a
it.
cigarette.
Anyone? Mark, would you like to add anything?
Kypros, it's Mark Kilby.
Amazing.
All the way to Kosova. Hello, thank you very much. I think you've provided fantastic evidence for both of your talks. And I guess the challenge for the future, the evidence is irrefutable, really. I guess the challenge, especially for us in the UK, but probably around the world, is twofold. One is political influence, to influence our political masters, if you call them that, both for us within the National Health System and the Department of Health, to see the evidence and allow the change of practice that's not just dependent upon money. So that's the first thing. I guess the second challenge as well for us all is education of doctors, and still even in the UK, the use of ultrasound and the use of advanced ultrasound, and then having an open mind to be able to apply your findings is still, shall I be generous and say, not as widespread as it perhaps should be. So I just wondered on your, just reflecting your personal view, how you think we can try and break the deadlock, if you will to call it that, and try and move this forward, because the evidence you present for both reducing the risk of preeclampsia and being able to prevent preterm labour is irrefutable now, and it's hearts and minds.
Very much. If you allow me, I will give you a secret. I spoke to your wife 3 weeks ago, who is a major fetal medicine expert in Scotland. And I am gathering together a group of people because the new president of the Royal College of Obstetricians has been convinced by the argument that this is extraordinary, really. In England, we tortured people for 10 years to become obstetricians, And I find it extraordinary that in the country that invented ultrasound, you finish your training after 10 years and you don't know how to do an ultrasound scan. At King's College Hospital tonight, there will be a patient that will be admitted with, in the casualty department with a hemorrhage, and you will not know whether this woman has an ectopic or whether the baby had a miscarriage or not. She will come into the hospital, and the next afternoon, she will be seen by a sonographer to find out what is the situation. I find that extraordinary. So I want us to campaign as a first step that all doctors that are training in obs and gynae should learn how to do an ultrasound scan. In Spain, where the training is 4 years, not 10 years, at the end of the 4-year period, all doctors know how to do a basic ultrasound scan. In Sweden, when they start their training, they spend the first 3 months in the gynecological ultrasound department to learn how to diagnose ectopic pregnancies and miscarriages. So that's number one. The second problem that we have in England, uniquely, unfortunately, that is not in the case in Greece, for example, is that obstetric ultrasound is in the hands of radiology departments. So we, as an obstetric community, have failed to control obstetric ultrasound. Every time you go where somebody in it, that the sonographer should be doing uterine artery Doppler or cervical assessment, the radiology department say we are very busy and we will not do it. It's a battle that we lost when we lost control of obstetric ultrasound. It's a more difficult battle to win. I am planning with your wife and the president of the college, Alison, who is fantastic, and she is convinced by our need to campaign for these things, to see the health minister. But the government yesterday has decided to kill the health minister because he's quite attractive and he speaks very well. Our prime minister is very threatened by him, so they released yesterday some news that there is a conspiracy for him to overthrow the prime minister. So I think they have decided to kill him off. But he's quite competent. I think we can convince him. That's all I have to say, Mark. We have to fight.
Well, thank you very much for that. You were successful.
You can include me as well in that journey, because I had the same dilemma, raised the issue that in obstetrics, it's no longer required to learn ultrasound. Forget about it. One of the trainee came from another country, from our world, your world, and on his first on-call night, he did ultrasound, and they complained about him, that it was not his job. Can you believe that? He had to defend himself in Britain.
That's what happens at King's, in my hospital.
Yes, the same thing happened. So I did the same thing in Wales, and I'm working on it, and we should perhaps combine our forces.
Thank you. So, thank you very much. I'm glad that Abu and Mark, so you gathered a very good group of people to participate in your Congress.
Well, I'm hoping to see you in Cardiff next year, hopefully.
Thank you. I was in Chester last week.
All right.
When they had an obstetric Welsh meeting of obstetricians in Chester.
Oh, thank you very much. But next year we'll invite you, so hope to see you there. Take care.
Thank you. Bye-bye. Bye-bye.